Okay, thank you for having a seat. We have plenty of seating up here at the front. Plenty of seating. All right, I am very excited to introduce our next presenter, who is back by popular demand. Dr. Brad McDaniels is an assistant professor and coordinator in the Rehabilitation Studies program at the University of North Texas. His research centers on the neuropsychiatric manifestations of Parkinson's disease, with a particular focus on apathy, loneliness, social isolation, and demoralization. In addition to exploring the challenges faced by individuals with Parkinson's, Dr. McDaniels is deeply committed to identifying and validating interventions that can improve quality of life and potentially alter the course of the disease. His work emphasizes powerful psychological tools such as resiliency, self-efficacy, psychological flexibility, gratitude, spirituality, coping skills, and positive psychological capital. His article, From Hopelessness to Hope, Addressing Demoralization in Parkinson's Disease, was recently published in the Journal of Movement Disorders Clinical Practice, and it quickly became the most read article in the first 2 weeks after its release, a testament to the relevance and impact of his work. Dr. McDaniels also serves on the DAPS Medical Advisory Board, and we are incredibly fortunate to have him with us today. Please join me in giving a warm welcome to Dr. Bradley McDaniels.
Thanks, Leisha. We got me on? Yeah, we're on. Thank you, Leisha, for that. That's you didn't need to clap just yet. I'm not sure how this will go, but we'll see. But I'm always grateful to be back here with DAPS. The work that Leisha and Keisha are doing is tremendous, and I'm grateful to see you guys. I love being around the Parkinson's community. I've met so many wonderful people, and it helps me. Many of you know me. My mom has Parkinson's. She was diagnosed 14 years ago. That was the impetus for my getting into Parkinson's research, and that's what I spend my days doing, is figuring out how I can make her life and your lives better one day at a time. So, all right, it's working. So we're going to talk a little bit today about demoralization. You heard Alicia mention that. Okay. And we're going to talk about what it is. We're going to talk about why it matters. We're going to talk about how does it differ from depression. Right? It's a word that's thrown around a lot, but I'm not sure that we define it really well. So we're going to talk a little bit about that today. Why it happens, and most importantly, what do we do? I think oftentimes we as researchers do a really good job of describing problems, but oftentimes we do a poor job of saying, what do we do about it? Right? It's not so great to know that there's a problem if there's not a treatment for it. Right? So we're going to talk a little bit about what do we do next. So as you all in this room know, I'm preaching to the choir. Once you receive a Parkinson's diagnosis, a lot of things happen, right? There's a lot of challenges that are associated with it. We have physical challenges, right? You have tremor, you have gait abnormalities, speech changes, cognitive changes that begin to happen. We have emotional challenges, right? Depression, anxiety, things like that. I think that many of you have probably seen those things along the way. And just as an aside, everything that I share today is just as pertinent for the care partner as it is for the person with Parkinson's. Right? I don't specifically say that anywhere in the talk, but it is. So it gives you something to pay attention to. If Parkinson's affects you socially, right? Maybe you don't interact as much as you used to before because of some of these things. And then spiritually, right? Potentially your meaning in life changes. Your identity changes. We're going to talk about that as we move along. So this is a busy slide. We had a paper a year and a half ago about delivering the diagnosis of Parkinson's disease and doing that with compassion. Some of the people who were on this paper with us are people who have Parkinson's disease. And we have a few clinicians on here and a few patients. And we talked about what are some of the things that common reactions to Parkinson's disease, right? Reactive depression is very common. Anxiety, regular depression, uncertainty, maybe even hopelessness, demoralization, right? We talked about it in this paper, and then the fun part was we got to write about what that means in a follow-up paper to this. It was just published a couple of months ago. So the operative question now is, what is demoralization? And why are we even talking about it? Does it matter? I submit that it does. Demoralization, the formal definition, is a persistent inability to cope. And Clark and Kissane published their work many years ago when they introduced this topic to the medical community. It hasn't received a ton of attention, and we're trying to change that. And so really what he called it was an interesting word in the second list there. It's called subjective incompetence. That's kind of a pejorative term, right? If I tell you you're subjectively incompetent, that might not be taken the right way. But really all that means is I don't have the ability to cope with the challenges that I'm facing in my life, i.e. Parkinson's disease, and all of the things that come from Parkinson's disease, right? So as we look deeper into the definition of demoralization, we see a helplessness. I don't know how to help myself with this disease that I have. See a hopelessness, right? So we heard from the last presenter that, and you all know this, Parkinson's disease is a chronic, which means it's not going to stop, neurodegenerative, which means it's going to continue to break down over time, and as it stands right now, there's nothing we can do to reverse it. So it's going to get worse, right? That's the one thing we can pretty much guarantee about Parkinson's disease is it will progress over time. So we can understand how you might feel hopeless. Then we think about meaninglessness. This is really an area that we found interesting as we looked into the research on demoralization. Most of the research comes from the cancer literature. People who are in stage 4 cancer in palliative care find that they have oftentimes given up. No hope, nothing to do for them, and life is now meaningless. And so we found that in the literature, and we said, why are we not really talking about this in PD? Because it's really no different, right? So this is kind of, I wanted to give you this as a starting point for why we're talking about it, so that you know where we're at. Does it differ from depression? And oftentimes, I think that's the problem in the clinical setting, is clinicians will see someone come in with some of these symptoms. You just look depressed. The way that you describe your life sounds depressed. But there are some clinical differences between the two that a doctor can differentiate them. And the main one is someone who is demoralized. I talked about subjective incompetence. They will describe their inability to cope. They don't know what to do. Someone who's clinically depressed has what's called anhedonia, which means you cannot experience pleasure in your life. And so the way we look at both of those is someone who's demoralized, who feels helpless and hopeless, can still experience pleasure in activities. Grandkids come over. They still experience pleasure with that. But yet they still feel helpless and hopeless. So that's one of the easiest ways to differentiate the two. The other way is response to medication. Many times, depression will respond to medications. SSRI, SNRI, we've got a variety of meds that are used to treat chemical depression, right? Demoralization won't. Demoralization is a behavior challenge, and so we need to treat it behaviorally rather than through a med. So if a doctor gives a demoralized patient an SSRI, they're probably not going to improve, unless they have comorbid depression, and they often co-occur. So it's really, how do we treat the person who's demoralized? We talked about some of these. Why demoralization? Why does it occur in Parkinson's? Kind of an obvious question to this group, right? You've got these motor symptoms that just keep getting worse. Meds aren't working as effectively as they used to. Maybe there are role changes in my life. My identity is not what it was before, and I feel helpless and hopeless. There's very limited work on demoralization in PD. There have been a couple of studies that were done basically trying to quantify how much demoralization or how common demoralization is in the PD world. the research that's been studied says 20%. I find that very underestimated. I would bet it's significantly higher than that. We know depression is higher than 20% in the Parkinson's community. So I would say demoralization is much higher. So there clearly needs to be some more work done, quantifying it, and more importantly, looking at some studies about how do we treat it and can we make it improve. So this is a figure from the paper that we did, and it kind of walks you through this process of how we end up with demoralization, right? So someone prior to a Parkinson's diagnosis, you've kind of got this sense of control over your life. You kind of had this idea about how things are going to go, how you're going to retire and you're going to have grandkids and you're going to have all these things in life. You're going to travel, and then you end up with this Parkinson's diagnosis. And that idea of the things that you're going to experience in life, it's called your assumptive world. And all of a sudden, that assumptive world changes. And I begin to feel like I don't have control over how my life's going, right? You lack a sense of self. You begin to feel anxious. You begin to feel helpless. You can't express feelings as much as you used to. You don't even know what to do. How am I going to deal with this diagnosis? I don't know. Then you begin to seek help, right? You go to your primary care doctor, tell them about your issues. They may send you to a general neurologist, or they may send you to a movement disorder specialist. Depending on the response that you get from that specialist can dramatically improve or dramatically change the trajectory of how you feel, right? Probably there are people in this room who have been to see a specialist who got a poor response from them. They weren't heard. They didn't feel valued, even stigmatized. We see in the literature, we've got a paper that I'll talk about in a minute, we wrote about stigma and the significant role that stigma plays. And it's hard to believe that it happens in the medical community, but it does, right? So if you don't feel like you're heard and you've been dismissed, you may start to feel ashamed. You may start to feel isolated. You may start to feel alone. Nobody cares. There's nobody here to help me, which clearly takes you to a place of helplessness and hopelessness, right? Then what happens after that? Social isolation, withdrawal, increased anxiety, depression, apathy, all of which can co-occur with demoralization. Even thoughts of ending your life. Interestingly, in the literature, there is people who are demoralized are at a greater risk of suicidal ideation than people who are depressed. I didn't know that when I began researching this topic. I would have said just the opposite. I would have said depression is the indicator for someone who's going to think about suicide. So it's a serious issue, right? Uh-oh. I don't know what we did here. Tony, you back there? All right, we got a little ahead of ourselves here. Let me back up, get us to where we were. All right, this is where we were. Sorry for the delay. Gave you a second to breathe, take a drink. So, I just talked about stigma, right? And stigma is a real issue with Parkinson's disease. Some of the research we looked at is 50% of people with Parkinson's say they've experienced discrimination as a result of their condition. And 50% of people with Parkinson's disease say that they have tried to hide their condition from other people. Why? Stigma, right? The judgment that is associated with that. And so this is a super busy slide. It was in the paper that we did, and I'll just quickly go through this. I'm not going to go in depth. But one of the issues with stigma in Parkinson's disease begins with the societal view of Parkinson's disease, right? We've always had that picture that's been around of Parkinson's disease forever, of older man with a walker or a cane bent over. And that's the view of Parkinson's disease that the world has, right? It's the view that I had before my mom got diagnosed. And then you hear about someone like Michael J. Fox, who's in his 30s, who gets Parkinson's. You go, he doesn't get Parkinson's. He's in his 30s, right? And so when we have that societal view of Parkinson's disease, it affects the way that people interact with us in public, right? Because of the symptoms, the tremor, the drooling, the facial masking, the incontinence, all of those things that can cause people to label us, have stereotypes about us, then those issues become discrimination. The way that maybe at my job, someone is treating me differently because of Parkinson's disease. Maybe at a place where I go to dinner, I'm being treated differently because of my Parkinson's disease. Then I begin to internalize that stigma, and I feel like I'm less than. There's shame, there's guilt associated with that. And as a result, the far right block there is social isolation, strained relationships, depression, anxiety gets even worse than what you already had, right? So now it's just compounding. And you conceal it, and it just becomes more problematic. So what do we do about it? The mitigating factors. We learn to cope. We have coping strategies. We're going to talk about these in just a minute or two. Get to a place of acceptance. We need to educate the community more on Parkinson's disease. The Parkinson's community is doing a much better job of that. We've been working on changing the pictures of what Parkinson's disease looks like so that people understand that it's not just a disease of old age. And here's the other piece, right? There is a double stigma often with Parkinson's, that you have Parkinson's disease, plus you may be stigmatized because of your age. So now you're getting stigmatized in multiple ways. You might also throw in there if you're a minority. Now you've got that stigma on top of that. Maybe if you're a female, there's that, right? I mean, you can see the cascade of what this does and how it can make someone feel demoralized. So then I talked about stigma and what it can result in, and one of the things is loneliness, right? You begin to socially isolate because you feel like you're being judged by other people. Does loneliness matter? Yeah, right? We didn't hear that much talk about loneliness before COVID. I think everybody knew that it could be an issue. Since COVID, loneliness research has blown up. This was put out by the Surgeon General a couple of years ago. Loneliness is more detrimental to your health than smoking 15 cigarettes a day. Wow, right? How about this? Some of my colleagues published this paper a few years ago looking at the impact of loneliness. It's a difficult slide to comprehend, but all I'll tell you, the very top bar is looking at exercising 30 minutes a day, 7 days a week. And it's got a negative sign with it. And what that's measuring is if you exercise 30 minutes a day, 7 days a week, measures on a Pro-PD score, which measure your motor scores and your non-motor scores, go down, which means they get better, right? Makes sense. We just heard it from the last presenter. When you exercise, things improve. Very bottom line, for people who are lonely, their motor and non-motor scores got worse because of loneliness. In fact, their scores got worse than how good the scores got for people who exercised. It's an interesting finding, right? That's how important loneliness is, and that's why it matters. So then, as we're struggling with this stigma, we're struggling with loneliness, all of these things are going on in our lives. And one of the things that's really interesting to think about is identity. How does my identity change as a result of my PD? And it does, right? And one of the models that I'm very interested in is called the Disability Centrality Model. Malachi Bishop, who's now at the University of Wisconsin-Madison, put this together back in 2005. And really what he said was how much a chronic illness or disability negatively impacts one's life is based on how the areas in their life are affected that matter to them. So, if your work is central to your identity and how you feel, and because of your Parkinson's disease and its progression, you can no longer work, that's going to dramatically affect your quality of life. Now, if another person, work doesn't really matter to them, and they're doing it just because, and they were ready to retire anyways, and they get out, it may not affect their quality of life as much. So you see where I'm going with that. Fill in the blank with what it is. But whatever the things are that you value, if those things are affected by your Parkinson's disease, it's dramatically going to affect your quality of life and your identity. And some of the things that do that are role loss, right? Maybe you were the primary breadwinner in your home. Now all of a sudden you can't do that. That was my identity. That's who I am. Now that's gone. Maybe you were the one who kept the house in order. You did everything at home, cooked the meals, you cleaned the house, you did the laundry, all of that. Now I have Parkinson's disease, and because of the physical symptoms that I have associated with that, I can no longer do those things like I used to. Role change, right? Somebody else has got to step in. Now I feel shame. Now I feel guilt because I can't do the things I used to do. Depression, anxiety, demoralization follow, right? Identity is a big deal. It's another area that hasn't really been looked at in Parkinson's disease. But what we know as if those areas that are central to your life are affected by Parkinson's disease, quality of life always goes down. It always. So think about your own life. What are the areas that have been most impacted by your Parkinson's disease? And are there some of those areas that were really important to you, that really made you who you are? If that's the case, you could see how there's a correlation between quality of life and those things. Another really busy slide. This is the paper we just published looking at demoralization and Parkinson's disease. The top line is biological. That's the piece that's, we know, tremor, drooling, constipation, anxiety, depression. Those things all address outcomes. The best way to control those is your movement disorder doc making sure that you're on the proper meds for your motor dysfunction, right? That's the easy way. The other way is maybe you need to see a counselor, right? There's a lot of stigma surrounding going to counseling, right? Oftentimes there's a lot of resistance going to counseling. I would submit that any person sitting in this room or in the state of Texas, for that matter, can benefit from going to counseling, right? I won't get into a government conversation, but they can benefit from it too. So then the second box is look at psychological. All of those things, the stigma, psychological distress, self-blame, low self-esteem. What do we do with those? We begin to think about how do you instill hope in someone? Because, right, we talked about demoralization is hopelessness. So if you lack hope, the solution is to find hope, right? So we find ways to instill hope, build resilience, begin to get some autonomy in your life where you can make some of your own decisions and begin to direct the path that you're going down. Social, the loneliness, right? Big deal. What do we do? Again, Dr. El Nazar before talked about that she tells people, somebody asked about chores over here, and she said that she will write a prescription for that, right? We've written about that in a couple of our papers. It's called social prescribing. Doctors are really good at writing you a prescription for medications, right? When's the last time your doctor wrote you a prescription for make sure that you have coffee with a friend twice a week? Or actually writing you a prescription to make sure that you exercise 5 days a week. And group exercise is even better, right? Because now you're filling the social piece, plus you're getting the physical benefits of exercise. Those things are important. Find someone to interact with, be a mentor, right? Especially if you're new to the PD world. You got a bunch of people in this room who can help you as you think about, are these things that I'm experiencing normal? Those are tough when you're brand new. I remember my mom asking me those questions, and I didn't know at the time. Now she calls me. Her issues are mainly cognitive, and she calls me and she says, Brad, I keep forgetting stuff, and is it my Parkinson's? And I say, Mom, you're 80. Is it Parkinson's or age? And the answer is yes, right to that mild cognitive impairment happens in normal aging, right? Then throw in a neurodegenerative condition, and now all of a sudden things worsen. And lastly, the treatment team, right? The treatment team is essential as we think about Parkinson's disease. And again, another paper that we did, I got the date wrong there. I don't know what year that is. But, but making sure that we have a multidisciplinary team working with us, right? It's much more than just your movement disorder specialist, right? This disease affects every area of our lives, right? So it's finding a physical therapist who can help. I see Mike in the back of the room, right? Getting with someone who can help you do the types of exercise you need to do to improve your quality of life, improve your motor functioning. We talked about counseling, finding a counselor, finding maybe a spiritual advisor who can help you find meaning and purpose in your life, right? But it's critical that all of these things are intact. Healthy diet, right? Those things matter. Making sure I get adequate sleep. These things all affect our lives. It's much more than take your Cinemet 3 times a day. Matters. That's important. There's more to it than that. So now we get to, Brad, that's great. You told us about demoralization. You've talked about loneliness and stigma and depression. And thanks for getting our mood up, right? But, so the question becomes now, what in the world can I do to make this thing better in my life? I'm going to give you some really simple strategies. The first one goes without saying. Counseling is always a good choice. Cognitive behavioral therapy is a very effective way to get counseling, and it works, right? Talk to someone who's a professional. Sometimes that's not, you can't get to someone who does that. It may be difficult getting into someone. Online counseling is very common now, and it's pretty easy to find someone that you can get in with. So that aside, what can you do in your life to help? Change the narrative. One of the things I mentioned before is begin to find hope. Hope is not just naive optimism, right? It's not the Pollyanna attitude that everything in life's going to be great. It's real, right? Parkinson's is progressive, and it's going to get worse. But it's a belief that we can change things moving forward. How do we begin to establish this? You know, Snyder developed a hope theory, 25 years ago almost. And the ways that he described it was hope's made up of 3 things. I need to have agency or the will to want to do things differently, to want to see my life differently. I need to have the tools, or what he called the pathways, i.e. coping strategies, to help me go from having the will to do something different to reach my goals. And the third piece that he said, you got to have a goal. So maybe we begin to set achievable goals. And we find different ways to accomplish those goals, right? More often than not, there's not just one way to get things done. Maybe the way you used to do it doesn't work anymore and you're losing hope. Maybe a conversation with someone at DAPS helps you find a new way to do what you didn't think you could do anymore, and now all of a sudden you have more hope. That's one way. Viktor Frankl. If you guys have heard me before, you know I love Viktor Frankl. If you have not read the book, Man's Search for Meaning, I highly recommend it, especially the first half. The second half is his counseling theory that he developed, which is fascinating too. But to read his story as a World War II concentration camp survivor is fascinating, and how meaning and purpose changes your life. So his quote, everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose your own way. It's a choice. It's a choice. How I feel is largely a choice. Oftentimes it's how I look at a situation, right? So resilience. It's one of the things that you learn from Viktor Frankl. And resilience is just simply the capacity for positive adaptation in the face of a stressor in life. The ability to bounce back, right? So life's going along fairly smoothly, things are good. You get diagnosed with Parkinson's disease, and there's a setback, right? All of a sudden now, my mental health's not what it was. My psychological well-being is not what it was. I begin to get to a place of acceptance in my life. I begin to realize that I have Parkinson's and there's really not anything I can do about it, but do the best that I can to live a good life despite it. And then I can get back to largely where I was before. Interesting thing about resilience. There's another positive psychological construct called post-traumatic growth. Resilience says you're going along in life and things are okay. I have a setback. I learn to deal with the setback and I go back to where I was. Okay? It's a return to homeostasis. Post-traumatic growth, on the other hand, says life's going along good. I have a setback. I work on some things. I grow. Now, I'm even better than I was before. It's counterintuitive to think about, but Viktor Frankl talks about it, and it's very real. So how do we build resilience? Resilience is a skill that can be built, and it just takes some practice. We'll start at the top, cultivate a growth mindset. Begin to look at things, areas in your life where you can do something differently to achieve the result that you want. Right? Developing some different coping strategies. Focus on what you can control versus what you can't. Right? I can't control my trimmer. Take my meds. I can't control when the off time is going to happen always. Right? That changes all the time. Stress, we talked about it in the last talk. And the question is, does stress affect Parkinson's? 100%. Every part of it. Motor and non-motor. We could get into the pathophysiology of how that works, but it absolutely does, and it affects your mood, right? Things get worse. Take action. Do something, right? We talked a little bit in the hope slide, but set an attainable goal and work to achieve that goal. You achieve it, and you begin to develop hope and resilience at the same time, right? Embrace failure as a learning opportunity. Just because you failed does not mean you are a failure. Failure is an identity statement. Failure goes back to shame, which is something about who I am. We all fail in every area of our lives. I'll fail before I get home today at something, right? But it's how can we fail and go, what did I learn about that, and now I'm going to do something different the next time. So was that a failure? I don't know. I mean, because you learned something new, right? Build a support network. That works on a couple of things, right? Because now you've got somebody who can help you think about how to do things differently, but you're also dealing with the loneliness issue that we just learned about was so essential. Have a quality support network. Foster meaning and purpose. Again, those of you that have heard me in the past know I love talking about meaning and purpose. Everything in your life that's going poorly will improve when you have meaning and purpose. The literature is abundantly clear. Even mortality gets lower for people who have meaning and purpose. Right? In fact, there was just a study published last week from University of California, Davis, that showed meaning and purpose. People who had high meaning and purpose had a 27% lower risk of dementia. Not bad, huh? I'll take that. And mortality on top of that? Decreased mortality? Pretty good. So one of the ways that we can do is figure out what our values are in our lives, because our values determine what we think is meaningful, right? And so one area that, and I'll share these slides. I always share them with Keisha. So you guys are welcome to have them, do whatever you want with them. They're not proprietary. But Value and Action Survey is that link that's on here. And you can go in there and find out what your values are. That you're helpful, that you're courageous, that you're loving, right? What are those things? It'll give you a whole list, and it's free to do. One of the ways to develop meaning is find these things that I value and figure out a way to use them in my daily life, right? If I'm courageous and it's one of my values, how can I attack problems in my life in a way that shows that I'm courageous? Maybe don't give up, right? Keep pushing forward despite. Engage in acts of kindness, pro-social behavior. Just do nice things for other people. Again, another study that was just published, Sonia Lyambursky from out in California, looked at a study that people who did pro-social things had significantly better subjective well-being in their lives. despite what issues they're having, despite chronic illness or anything else. Just do something nice for someone else, right? You're in line at Starbucks, buy the guy's coffee that's behind you. Yeah, pretty simple. Because what happens is when we do that, we feel better. And meaning and purpose is significantly associated with pro-social behavior. Increase social connections. All of the research on meaning and purpose, you'll find there's a ton of way to find meaning and purpose. But if you look at the research, do a meta-analysis, and you see what's there, there are 3 things that are common in every study that looks at meaning and purpose: work, relationships, and spirituality. Those are the 3 things that, by and large, help people find meaning in life. Make sure you're engaged in relationships with other people. Engage in spiritual and reflective practices. We know it's proven. And gratitude. Gratitude is such a simple concept, but we forget to use it every day. So Robert Emmons is the foremost researcher in the world of gratitude. He's been researching gratitude for 30 years. He says it's the most transformative force in the cosmos. Wow. An essential lubricant to social interaction. Gratitude matters. Look at the things that we see there. Gratitude decreases demoralization, depression, anxiety, and stress. Pretty good. I'll live with that. But it also increases hope, optimism, meaning in life, resilience, and happiness. That's a pretty good win just for living a life that's filled with gratitude. How do I do that, Brad? Great question. 3 good things. Every day, write down 3 good things that happened in your life that day. Real simple. 3 good things. I got to sleep in today. Great. We didn't get to today, right? We'll skip that one. So, you got a good lunch. That's what's going to happen today, right? You guys are going to get to hear Ray Dorsey this afternoon. That's a really good thing, right? 3 things every day. Start a gratitude journal, right? I put 2 to 3 times a week. Do it every day, right? Every night when you go to bed, write down 3 things that you're grateful for that day. I'll tell you a quick story. I know we're running out of time. I was working in a substance use treatment center years ago, and this guy was coming to me, and we were talking about gratitude. And I said, I want you to make a gratitude list. Bring it to me when you're done. He said, okay. Next day, he comes and he says, Brad, I'm done. I'm like, really? Let me see it. And he shows me the list, and he's got a sheet of paper lined down the middle and 1/2 of the page filled. And I took it, I ripped it up, and I threw it away. And he gave me a funny look, like, what are you? And I said, you know what? Let me help you get started. You have 2 eyes, 2 ears, a nose, a mouth, 5 fingers on each hand. You can walk, you can talk, you can write, you can communicate. Let's start there. And what the reminder is, and I need to be reminded of that, is all the things that I take for granted every day that I wouldn't include on my gratitude list, right? Write a gratitude list. Express gratitude. Tell somebody you're grateful for them. More importantly, tell them why. I'm so grateful for the work that you did, Leisha, to set up this conference today. It matters. The why matters, right? Mental subtraction of positives. What is that? That sounds weird. It is kind of weird. But take something in your life that's positive. Imagine if that was not there. How would your life be? Your spouse is not with you now. Whatever it is. So that will automatically give you gratitude for that thing because you go, man, if I didn't have that in my life, things would not be going well at all. Maybe it's your movement disorder doctor. Maybe it's DAPS, right? Whatever it is. And lastly, cognitive reframing. Again, looking at setbacks not as failures, but as opportunities to grow, as a learning experience rather than a failure. So if you remember 4 things, I laughingly say 3 because when I first did this slide, I wrote 3, and somebody looked at it and they said, why do you say 3, but you got 4? Yeah, I tend to do that from time to time. 4 things. Demoralization is understandable and workable. It's treatable, right? You may, now that you've heard this, you may go, I get what demoralization is. I've experienced some of those things in my daily life. Now we know some things to do about it. Get hope, develop resilience, find meaning and purpose in your life, pursue action, restore agency, hope, and resilience. Gratitude works wonders. Have some gratitude in your life. Watch what happens when you begin to live a life that's full of gratitude. I promise you it'll change your life. Social connection. Find a group. Find some people, right? Get involved. Stay involved. Reach out. Make a phone call. Have coffee with a friend. It's all right to connect. That's all I've got. See, I love using this slide with this group because y'all know who Porky Pig was, right? I use this slide with my students and they don't know. They're like, who's Porky Pig? They don't even know what his name is. They go, what is this, right? And so I got to use a SpongeBob thing that I put on my slides for my classes because they all know who SpongeBob is. I don't know who SpongeBob is, but that's it. I'm happy to field any questions, and you guys are welcome to email me anytime. If you have a question, anything I can help you with. Somebody asked about the demoralization study. What I'll do is I'll actually make sure. I think you guys have it.
I'll make sure everyone
Keisha's
has
got
yes.
it, so feel free to reach out to them or me, and I'll get you any research that you want.
Can we take questions just for
Absolutely.
5 minutes?
For sure.
5 minutes. Anyone have any questions? Any questions? No? You guys are quiet.
I must have done well.
Yep. Our first one. Yay.
Uh-oh.
Hello.
Hi.
My background is in counseling, and I was listening and going back into my graduate and undergrad work when you were presenting, and I was like, well, that's existentialism, and then we have cognitive behavioral. One that always interested me was narrative therapy, and I saw that possibly moving through there. I wondered if your position on narrative therapy as it applies to somebody with Parkinson's.
Narrative therapy is what she asked about, and it's a fantastic way to deal with struggles in life. In fact, I'm working with a guy who's out in California now. He started an organization called Yes and Exercise. His name's Robert Cochran. And he does a ton of work with looking at the hero in a journey and looking at how if you were writing a story about your life from the third person, you begin to see things in your life that you didn't see when you're just actually living your life. And that's really what narrative therapy is, right? It's beginning to tell the story and to see how my life has progressed, how it's going, what I can do to change it. So yes, narrative therapy is great. And narrative therapy is something that you can do even without the guidance of a therapist. I mean, you can go online and search narrative therapy, right? I mean, AI will pretty much give you anything you want. You can probably ask for dinner on AI, and it'll show up at your door. Kind of weird, but yeah, hopefully that helps. Hey, Keisha.
Right here.
Brad, I wish that all the folks on TV that do these sports interviews, that you hadn't taught them what the word resilience. Everybody out there says the reason we won today is because of resilience. My question to you is, in the business world, there's a theory on motivation where they talk about having the want to and the how to and the opportunity to,
Yeah.
which is real similar to what you just showed. I wonder if you could say something about how opportunity to might fit in your...
Yeah, and thanks, Dan. And one of the things that you said that made me think is there's always a challenge when we talk about things in my life that I can't do. And Dan alluded to, there's semantics matter, saying I can't versus I won't. And that's kind of what we're going to. And the other thing that Dan mentioned is finding opportunities. Part of that means, and one of the slides that I had was action, purposeful action. It's seeking out opportunities, seeking out things that you can get involved in. You know, one of the things I've learned so well from the Parkinson's community is people who have found things that they're engaged in that they absolutely love post-diagnosis. One of the areas that sticks out to me is art. People who have never done anything with art, all of a sudden, post-Parkinson's diagnosis, maybe they can't golf anymore, or they can't run marathons anymore. And they're looking for something to fill that void, an opportunity to fill that void. And they find it and they go, wow, I never knew the value of art. Never would have thought about it, right? So again, here's the cognitive reframing that even though I lost this area of my life, I've developed this new area that I never knew I loved. I developed new friendships all the time with people in this room because of Parkinson's disease, right? So I think that's a great point, Dan, looking at opportunities. Yeah, Keisha?
Right here.
In this context, what do you mean by spiritual? You were saying that there are 3 areas that were greatly affected, and I've always had a tough time grasping what spiritual means.
Yeah, great question, right? I think, again, that's one of those challenges that we often conflate the words spiritual and religion, right? Meaning we say them interchangeably, and that's not necessarily true. You can be religious and not spiritual, and you can be spiritual and not religious. They're not mutually exclusive terms. So when I talk about spirituality, and most of the research that talks about it, it's connection with something greater than you. Oftentimes, people will define spirituality as, I find a spiritual connection in nature. I find a spiritual connection when I pray. Who do you pray to? I don't know, right? We could probably go around the room and take a survey, and people may pray to different entities, right? But it's looking at a connection with another being greater than you. That's the easiest definition of spirituality, and there are lots of ways to find it, and one of the ways is just mindfulness, remaining in the moment where I'm at. I've got a friend who always says, I know we're running out here, Brad, make sure you're where your feet are. Right here, right? Thinking about what's going on in my life right now and what are the things I need to face and deal with. That can be a spiritual connection that happens in my life. But great question.
Oh, I'm going to take this gentleman right here.
Do these states cause failures to be, memories of failures to be resurrected more frequently and with more meaning?
Does demoralization cause that?
Yes.
It's a good question. I don't know. I don't know the answer to that. I think part of it would be depending on my mindset, if I'm focusing on the things in my life that I have failed at and I'm continuing to remind myself of those, I would argue that my demoralization is going to get worse, right? And there's when the cognitive shift happens. My wife and I have done some marriage counseling with people. And one of the things that we share all the time is I'll tell folks, I'll say, what are the 5 things about your spouse that drive you absolutely insane? Right? And they know those, right? Oh, yeah, the way she tries to control me all the time, whatever it is, right? But what about the 1,000 things that they do that you love about them, right? So here's what I can tell you, is whichever list you look at is going to determine your outlook. If I look at the things that my wife irritates me about, I'm going to be angry and I'm going to be resentful. But if I remember the things that she does that I love, I'm happy. So part of it's just a cognitive shift, but I don't know if it makes you remember those more. I think a lot of it depends on your personality and how you view them. Yes?
I would like to know all these stages and how you perceive them. That and exercising will it slow down the progression?
Exercise does slow down the progression. That's what we heard in the last.
But
Coupled with this?
Yes.
Yeah. So what happens with demoralization is, again, we talked a little bit about stress, and I didn't really get into that, but cortisol causes problems in our bodies when we have stress. The HPA axis and the way that works can increase our cortisol, increases stress, increases motor function, decreases mood, right? Okay. So there's definitely a relationship to the way that works along the way, and exercise decreases stress in our lives. So therefore, you would think that by exercising, stress is getting better. Therefore, these other things are also not getting worse.
But at the same time, these different avenues also work for the good of everyone.
Absolutely. Yeah. When you have more gratitude, The research is clear. You have less stress. People with higher meaning in life have lower stress, have lower depression, have lower anxiety. So yeah, it's a win-win. You're getting it from both ends. Hi.
We're going to take our last question right here.
Okay.
Yeah, when you're talking about value, I've just been doing some work with my therapist. I had a gorge rise up about a year ago where I refused to exercise, and I would not do it.
Yeah.
Absolutely. And it presented many emotional challenges. You know. So I was working with Dr. Simonson, and we began to explore my core values. What excites me? What brings me joy? And two of them are my art, and the second one is my spirituality. So we talked for a while. And an example of putting this into play, I now am taking walks with God. And this thing that brings me joy, I take with me on the walk, and it is not drudgery anymore.
Yeah.
And secondly, my art, I do narrative photography, and I'm going to do that at the gym.
Yeah.
The mechanisms of the machines, the people, all of that. But those are some concrete examples of value bringing joy into my life.
You know, that's a great point. And one last thing before we shut it here is that you made me think of is when I talk to my dad, he'll go, Brad, your mom's not exercising. And I go, yeah, but are you going with her? Right? And because they value their relationship, so why not take what I value into something that I'm not really sure I want to do, but now it becomes a different thing, right? So great. Thanks for bringing that up. All right.
Can we give a huge round of applause to Dr. McDaniels?